was as a pain and palliative care specialist that we had at the airport. So we maintained calmness. Then eye contact was maintained. Then the patient's mind was prepared before the news was broken to her. So then breaking the news. Now we made use of spikes. So we had to provide a conducive environment. We provided privacy so that everyone will not withdraw to start listening to what we are discussing with the patient. Then the patient's perspective was explored. What do you know? What do you know about this? Have you heard about this before? So then the patient was asked, patient, who do you want us to invite to be here with you, the person you trusted? So she called one of the children, so that as a treatment partner. Then acknowledged to about the two inmates were explored. Then we empathized with her and explained the strategy modalities we used in treatment. Then, building the patient's hope, we tried to explain to her that having this image is not the end of the world, it's not a death sentence. Have many patients that passed through and have recovered and living well. The executions, we made use of all. We told her everything she needed to know. Then told that she can have a form consent. So also part 3, the pain management. She was having sharp, stabbing chest pain. So the drug that was used, we used the mild analgesia and the moderate opioid. The mild 6 hourly, 1 gram 6 hourly, 24 QDS daily, like that. So then for the compound the 2 drugs were used. Then for the non-pharmacological treatment, we made use of the music, distraction, provided social support, then we cancel. Then teams, the use of electric current. Then we looked at 4, symptom management. She had weight loss, we invited a nutritionist to provide counseling on the types of disability, proteins, vitamins, water, which is very important to prevent dehydration because of the night sweat. Then the pleural effusion, the undersea water drainage procedure was done to evacuate the pulse in the chest. Then we provided oxygen. Then the non-pharmacological, we assess the pharmacological management. So we monitor for drug compliance with our medication. Then the drugs used, TB and HIV. For TB, ethambutol, pyridoxine, isoniazid, then spiritin. Then for the HIV, aceclofan and ephedrine, we provided immune boosters too, and antioxidants. Then for tax 5, grief and loss, we anticipated that she would have lost her job. You know, she was working in a shopping mall and the form of embarrassment, and as she comes, there will be a level of tiredness. She will not be able to carry all the activities of the baby. So she has to stay at home. So we anticipated that before the other person must have been taken over. So loss of job is part of our loss. Then obviously then the inability to go to place of worship. Then now she has lost weight, she has lost weight, so the leanness. Say, hey, what's wrong with you? Why are you like this? So the help we provided, the family was carried along with the care, how to support her with everything they could. Then the counseling, we gave psychological reassurance, they assured her she would get better once she complied with all the treatment. The spiritual leader was invited. Then financially, since she could not retain her job presently, the occupational therapist was called to advocate for her for the change of her job, even after maybe they might give her a lesser job when she's okay, or she can work from home. Then also vocational skills. We talked about that too. Then, under the help, since we mentioned the mother-in-law, the sister, the children, the church, everywhere she is, those people have to be screened. Even the husband, we saw that the husband was a distant truck driver. Even this HIV we are talking about, you know, as they move around, it might be that the husband that brought the illness to, yes. Either way, sir. So the cultural, the taxi, the cultural spiritual aspect. So I've said it. I said the family was carried along then in the context of the culture. We tried to tailor the information along that line, and the pastor was invited to give spiritual support. Then task 7, those their team that collaborated in the care, the physician, the psychologist, medical psychologist, the social, the nurses, the pharmacists, the physiotherapists. When the work of the physician, the psychologist, teach the psychological aspect of the care counseling. Then the nurses to carry out medication, health education. This is what you should do about this. You have to adhere to your treatment, the type of food to be eating. Then the pharmacist in the disbursement of the medication. Then the physiotherapist. What about the chest breathing exercise, chest exercise, how to support the chest when she's coughing so that there will be reduction in the pain. Then pain management, psychological support.
Don't worry about that, guys.
Also, please let me add this. Because she's 30 years, we see that she's still sexually active. So we gave her psychological education to healthy, positive sexual habits.
Let's give another applause. That's the latest pain and palliative medicine specialist. That's a big one. Let's give everybody a round of applause. They are doing so well. But just to mention before I forget, the issue of the pain management. The pain is moderate, that's not so. And you said you gave what? Ogun. In pain and palliative medicine, but these are things you pick along the line. In pain and palliative medicine, we usually shy away from giving combination drugs that are combined. Ogun is a combined drugs. You have the codeine, 8 mg, some comes as 8 mg, some comes as 30 mg. And the paracetamol here is 500 mg. The problem where we usually shy away from using combined drugs is that sometimes you want to increase the dosage of one. But if you are using combined drugs, you'll be forced to increase. So you will run into problem when you want to increase the dosage of say codeine or paracetamol. So we used to say that we should not use combined drugs. You can use dihydrocodeine. Dihydrocodeine is demons. It's also a what? A weak opioid. You can start 15 milligram every 6 hours. Or you can use tramadol. Tramadol is available now, thank God. Yeah, it's available in the market. So you can use tramadol to treat the patient. Also, codeine, tramadol, and dihydrocodeine. That's a very good one. So, we are at the end of the case scenarios. And we are moving to the end of the program. So all we have to do now is question and answers. Question and answers, verifications. Thank God the guy is here, the father of palliative care is around before he takes his bag and go back to London. So we have the opportunity to benefit a lot from his words of knowledge and experience. So with what we have done yesterday and today, and I'm sure we have really benefited a lot. Just 2 days and the case scenarios are really very interesting, and we have really done so well. So any question, clarification on any aspect of palliative care that we have done yesterday?
Last question concerning the case study, case 4. We are discussing it. We are talking about the nutritional aspect. Since he's unconscious, I was the professor of the NGCC. But among us, they said there is no IBC, there is no NGCC. But then we should start the patient to diagnose.
That's a very good question. You see, that is for the woman that was unconscious for 28 days. If you remember when we were doing ethics, that was the case I used. Yes. There are a lot of ethical dilemmas. And the patient actually was an MG2 for the feeding, even for the morphine. The person that said that the patient does not have, the patient has pain. Unconscious patients do have pain. You will know how are you going to do? Yes. They will groaning, you will see them groaning, feeling uncomfortable. So you know they are in pain. Though they cannot talk. They cannot talk, but they are in pain. So you continue to give them their morphine through the NG2. And we actually did in this patient. Liver and morphine hourly through the NG2. And we were feeding PAP and some other supplements that they were giving to the majority to give through the work, through the NG2. You can't say because the patient is dying, patients suffer. No. Patients should not suffer until what? I think that answers the question. Any other question or clarification? I can see they are all now specialists in pain and palliative. So we know it's all questions, clarifications. Should the patient be fed? The patient is unconscious and she was on NG2. So the yes, it's a form of feeding now. If you can't feed per hour, you can feed through the NG2. You understand? Some will have given the option of total TPN, total parenteral nutrition, but we also look at ethics because we know what it will cost the patient to have total parenteral nutrition. Those are the ethics. You know, guy was even saying that these patients, fine, we can give ICU, palliative care in the ICU, but this kind of patient will benefit from ICU care. So that is the ethical care. Is it fair? Is it wise? Is it ethical? Are you acting in the best interest of the patient or the relatives or even the healthcare system? And that's where ethics comes in. Because you are blocking another person's bed by this patient to go for ICU. They actually wanted ICU, the relative. I said it. But after counseling them and telling them that the patient cannot benefit from ICU care, they opted for care on the ward because they don't want to go home for palliative care. Question?
I just want to ask, what's the role of palliative in psychiatry?
Yes. Thank you so much. Thank God God is here. God did a lot of work on palliative care in psychiatry. Any question you want to ask, just ask. The father of palliative care is here. So, and he did a lot of work in palliative care in psychiatry. Patients with dementia, patients with delirium. Yes, we have a lot of roles. And that's why the definition has really changed from life-threatening illness or life illness to what? To patients with serious illness. Because patients with dementia, for example, give impairment, especially dementia, they will need palliative care. In terms of giving them the physical, psychosocial, emotional, and spiritual care. And I'm sure Oga will also add to this. There is even what we call psychiatry, palliative care psychiatry palliative care, yes. It's a branch in what? It's an aspect in what? Palliative care. To see patients with, Dr. Kwewe even mentioned it when I was around that. There are some patients with schizophrenia that actually need palliative care. Because palliative care, anywhere there's suffering, palliative care will be very useful. And this suffering will not just be only physical, psychosocial. Some of them have abandoned school, some of them cannot go, some of them have a lot of social issues that you need palliative care to see them and discuss and find a way around it. In conjunction with the mental health. I'm sure God wants to say one or two things on this.
What else do you have to say? You have said everything. Throughout my lecture, I was mentioning your level of palliative care depends on how much you can innovate. You can go to any length. It depends on your ingenuity. So, it already has a place in psychiatry. It is already a specialty. So I hope our psychiatric department will buy into it. Palliative care in Nigeria, the first set of people are anesthetists. They are still doing it, anesthetists. I didn't get into palliative care through anesthesiology. How do I get into palliative care? I talked about majority through anesthesiology. I was Chairman Medical Advisory Committee and Director of Clinical Services and trained in Federal Medical Center Abeokuta 23 years ago. That was the post of Deputy Medical Director. I was very much there. I received a call from American Embassy that they are coming, they are bringing a nurse, every state nurse to come and give them a job at Federal Medical Center there. And I said, well, I don't entertain come too well. If you are really genuine, take your car from Lagos and come and meet me in the office. And they came. I organized the training for them. And that day, I always open with people. People came from Ijayi, Lantoro, all over. It was 2001. And we had meetings like this. When we had meetings like this, it's just like the parables in the Bible. Some of these parables, they are always very, it's not that they are key to it, but rather you give one or two things for it. And they say, when we give messages like this, some fall on the rock, some fall among the thorns, and some fall on the fertile soil, and they germinate and become big. That's part of the story here. So, we set up a committee, and we are going to do that before you leave. What is that going to do? That's all you are there. We are even taking you people to UK. So what is Italy going to do, and every other places like that? We are open. anybody. That's humanity. Your impact on human life. That's our goal. So, with that, that was how the innovation started. For example, we told you, we are still saying it, I'm still looking for it. We have almost 25 or more than 25 centers in Nigeria. We were the first to introduce HIV palliative medicine. And we are still running it today.
Please, bring out your main ticket, please.
You did not see my lectures. I'm in prison. The pictures are there. When we did hosted the national palliative care, which year was that? When we hosted national palliative care, I think 2015.
2015.
You were there, the backup. Yes, that's not very late. 2015.
Get the water outside.
At the backup university. We brought the whole of Nigeria. In fact, we were so smart that we did not even do it yet. We took it to the university to create that sensitization for them. And besides that, we involve Ijayi, we involve Lantoro, we involve everybody, we plan it together, we work collectively. So we are open to people, what do we want to give when others cannot do it? So, in fact, I'm a very man, the mother of palliative care in Africa. You know, they told her, and she called me, said, "For that, I have work to do." That was a marvelous work. Because they have never done the time in Nigeria. So what we do is international. We don't do all this, we do that. See the quality of training we are giving you. It has standard thing. We have seen it done all over. That is how you can learn, not giving all these things. And what do I want to bring out? The specialty that was imagined here was public health in palliative care. That was the thing, anybody who remember?
Yes.
Public health in palliative care. And it was because one of my doctors then moved from us and moved into public health, community medicine. And we wanted to go and start in there. But by the time I was going, we were already planning to start primary palliative care at the community level. But that project cannot go on again. We are covered this area, we are moving to that place. So if in 2015 minus 2023, we have already gone into public health approach to palliative care, that is innovation. But the newest thing now is psychiatry. Palliative psychiatry. The one they did last was palliative care in emergency and disaster zone. And people should also buy into palliative care in emergency and disaster zone if you have the opportunity. For example, when there was crisis, war in Nigeria, they were looking for palliative care specialists to come and help them in Nigeria. So you now ask yourself, what is a palliative care specialist going to do in Nigeria at one zone? Is it about cancer? Is it about people that is dying? No. We should be prepared. You can apply it to anywhere. Palliative care no specialist. Occupational palliative care occupational therapists. We have them. Physiotherapists are not here. We have physiotherapists. They are here. Okay, ma. Sorry, ma. We have physiotherapists who are just doing nothing other than palliative care. When I went to Uganda, people went to Uganda now. What's it called? Might be Uganda. And that was how I fashioned the HIV in this place. When the patient comes, you see a social worker in the office. You see the nutritionist. You see the physiotherapist. You see the chaplain. You see imam. In fact, they have worship center. In that worship center, Ahmadiyya is here. Pentecostal, they are there. Anglican are there, Reverend Father are there in the same place. So it is how far you want to take it, you will get there. There is no place you cannot involve. So I think I've answered your question. You can go any length. I will told you other aspects that you can do it. About the Ogun, what do you call it? I eat all this, don't like I read better this. So maybe because I did from my college. When I was doing my placement in India, just like that. And we have this patient, terrible pain, cancer, but was still at my level. And they always prescribe Kudamo and Kudamo. I was not getting better. And this my friend, in fact, he had this diploma in palliative care from University of Wales. The program the curriculum was brought from University of Wales to South Africa. The woman just finished, she had her masters. And she went to University of Cape Town that they should buy into this curriculum. And they bought into it. Not that he wanted to do it in London. They fought us up. We wanted to do it in Ibadan. They fought us up. You know, I'm not looking at them. Because the people that will suffer, I've done my own. Sweat, hard, spent all my money. So we tried to replicate it here. So in that university, trained us. By the time I got there, the woman who trained us was almost because she has been about 10 seconds before in South Africa. But the first plan, my mother is still here now. But if you don't need to make people noise about yourself, you don't want to buy. So nobody can mess it up. They are still there, people still see it. And believe it, I want to do everything in palliative medicine. The woman that was the convener has only MSc palliative care. It's not the professor, it's not the PhD holder. And he had trained 100 palliative care specialists in the university. People are coming from Canada. Of course, the place where they have been very well recognized. One of our boys who follow us, our copper was the second palliative care physician Nigeria ever was our copper. And there was another set after. That was Dr. Kolawole said. That was Dr. said. The guy who finished with Dr. Kolawole is in Canada now. So the training is good. We will encourage to have the contact. Let's make that contact. So the qualification I was talking about, this guy said, thank God. What I do is here. He said, and then it's Palliative is here, is a great specialist. Palliative is your own headache. And I look, I reflected. We that more. We could that more and that. That's what they use here. So they don't have medication. As a matter of fact, the medical director of that hospital, Cancer Institute, Southeast India, his salary was $1,000 in a month. I said, Doc, what is happening? He said, he's worshiping you. He has had a good relief of pain. Just on that note, because we give the full dose of diet, and we give a full dose of paracetamol. It also happened here. We had an organ, and they were managing because it could not get better. So they called me. I don't want to tell you the story because because I didn't look for someone. He had nasopharyngeal, and after my assessment, I said, well, paracetamol, NSAID, and okay, that's what I'm going to give you. And the prince said, they have been taking this thing, it never worked. I said, it never worked. Well, maybe I have some other things, I don't know. But me, I know that it works when I do it. Maybe I have some incantation because you talk about incantation. And I put the patient on the tray and I left. We normally wait for about 2 days to make sure that the medication is working before we come. It is the amenity there, they have been calling the amenity. And when I got to the amenity, I saw the place because I had problem with them because I didn't know that it was another. Nobody told me it was another. So I saw the place. How is Kabezi? The Kabezi is why I know. Maybe I started eating for the first time. Okay. I went to the nursing station to confirm from the nurses how is Kabezi. Kabezi is sitting down now and get himself because I just finished here. When I got to the book, I transmitted Kabezi. But you have to do it, or else you won't let to kill you. The spiritual aspect, I don't want to discuss it. About me. On that case. This is the organ that whenever I come for social clinic, he comes to our clinic inside quarters. Doesn't even come there. They come and see. You can imagine the bonding, the communication. You understand? So, I think that place. Báwo ni o ní ha o ní pé ìyẹn ti lọ o ní bẹ́ẹ̀ ni pé wọ́n ló fi síbẹ̀ ẹ̀gbọ́n ló lè mú kú those is our impression those things push us to do yes it works all these people dey agree it works you can never replace the textbooks they are years of practices. One thing in my life, I'm almost crying because I have a lot to put in books for people to read, but I don't have to write. This is the time for me to sit down, have a source of ink, put it in books, and pass it on to the next generation. Because I have a lot to share. Because so many people in Nigeria, they are not doing it because they know the difference is clear. We have it, and we don't want to lie. I pray God will do this. To be able to sit down and train the next generation. There are so many and I did anesthesia for 20 years. Nobody give me a gift. This is an anesthesia for in the end of theatre, perioperative theatre. I joined in 1996 as a consultant anesthetic. They do CS, they take baby out, they go to the gynae ward, you know. Or in fact, they will delay them to 8 days so that they can bring Coca-Cola and rice and all those things. The anesthetics, the perioperative nurse, they will not even see one coke. I will always praise on them, continue to take coke until you get diabetes. They forget us, they always demands. It was not the body. And that was the part I left the place 20 years. I did it for 20 years. Yes, carrying out to the other part. That is carrying us here, Lagos. So, I can't believe it. When we started this, we were not making money. But the family of the patient became the family of us. For the first time in my life, the patient's daughter approached me. Doc, what is the size of your shoe? What is the size of your shirt? I don't know. Now she goes to Italy to buy all this thing. She wants to get it for me. I said no. God give me the privilege. I don't buy shirt. I don't buy anything. It's only when I travel, I go and pick what I need. And before they expire, I go and pay that. They offer me so many things like that. Some will even reject. Some will don't even have money. You're supposed to be giving them money. They say you must take. It's like that. It's sweet. So please, you may not be out there to say this tomorrow. Go to your center and relax it. I think we can go. You have question again? So we meet. So we meet tomorrow. Tomorrow is the clinical placement. Here we will see the patient read live. All what we have been talking about, we say read live. So there will be a pre-consultant program review
by 9 o'clock, here in the seminar room. From 9 to 10, we'll do a review of all the patients. That's what we manage to do. Everybody will contribute before we go to the ward. And the ward now starts 10 o'clock. Our clinic is in the afternoon, 12 o'clock. So some will be opportune to go for the ward, while another group will wait for the clinic. So 9. Let's be here by 9. So the ward now review 9 o'clock here. The ward now starts 10. So have a wonderful night. See you tomorrow.
Thanks for coming. Please let's come around during last
That's the number.
Well, I don't use it as call number. I don't think I use
Have you got it?
It's on my head.
Yes. She will be resuscitated.
She will try. She will try.
No, I know she will do it. I see her body language. She has not told me about, but I can see the
No, she probably she will try.
Yes.
Revive palliative. Where are we connecting water? This side or this side? Okay.